Welcome to This Week in Urology. This week we're covering 10 notable papers spanning prostate cancer diagnostic pathways and advanced therapeutics, reconstructive strategies for urethral disease, and optimization techniques in functional urology. Let's dive in. We begin with prostate cancer screening and the diagnostic pathway, where patient engagement and imaging quality represent critical gates. In a prospective randomized study, researchers evaluated 2 web-based electronic visits designed to help men make decisions about prostate cancer screening. The study randomized 3,200 screen-eligible men across diverse racial and ethnic groups in Kaiser Permanente, Northern California, to either a basic informational visit or an interactive visit that provided a personalized estimate of the risk of having an elevated prostate-specific antigen level based on age and race. While overall completion rates were relatively low at around 15%, with white men completing the visits at the highest rate and black men at the lowest, the interactive tool significantly enhanced decision-making. Among those who completed their assigned visit, patients in the interactive group were more likely to make a definitive screening decision and request a prostate-specific antigen test compared to those who received purely general information. This highlights the power of personalized data and patient-centered digital health tools, while also pointing to a persistent gap in engagement across different demographic groups. Once screening leads to clinical suspicion, the quality of subsequent imaging is paramount. A prospective study in BJU International evaluated how the quality of multiparametric magnetic resonance imaging, graded by the Prostate Imaging Quality, or PIQ-UAL score, affects diagnostic accuracy in 246 consecutive patients referred for biopsy. External scans were centrally reviewed by expert radiologists who reassessed both image quality and lesion grading. High-quality scans, defined as those with a PI-QoL score of 3, demonstrated significantly greater diagnostic accuracy for clinically significant prostate cancer, compared to low-quality scans scoring 1 or 2, with an area under the curve of 0.79 versus 0.66. High-quality scans also yielded a much lower proportion of indeterminate findings. Crucially, centralized expert review improved diagnostic accuracy across all scans and led to the reclassification of nearly half of the assessments. This demonstrates that securing high-quality scan acquisition and utilizing expert central review are essential steps to optimize diagnostic accuracy and prevent unnecessary biopsy procedures. To standardize the biopsy process following imaging, European Urology published the ProBio-PSY International Consensus. This project involved 34 international experts who underwent a 3-round modified Delphi process to harmonize patient selection, imaging, and biopsy techniques. The consensus strongly endorsed both biparametric and multiparametric magnetic resonance imaging within the diagnostic pathway, provided the scan quality is adequate. For the majority of local treatment planning scenarios, the panel concluded that a targeted plus perilesional biopsy scheme is sufficient. However, they noted that a single biopsy approach does not fit all clinical decisions, emphasizing that additional contralateral sampling remains necessary for specific indications, most notably when selecting candidates for focal therapy. This consensus establishes a standardized framework, reminding clinicians to tailor the biopsy approach to the specific management plan contemplated for the patient. Moving from diagnostics to the natural history of high-risk disease, a study in European Urology Focus analyzed the outcomes of 701 patients who met the inclusion criteria for the ongoing Proteus trial. This trial is evaluating perioperative apalutamide combined with androgen deprivation therapy in patients undergoing radical prostatectomy. Crucially, this study looked at the natural history of these patients when treated with surgery alone, without any perioperative systemic therapy. Interestingly, more than half of the patients eligible for the Proteus trial did not meet the traditional high-risk definitions established by the European Association of Urology, or the National Comprehensive Cancer Network. For the entire cohort, event-free survival rates were approximately 58% at 3 years and 46% at 5 years. Patients who met the Proteus criteria but did not meet the traditional high-risk classifications had more favorable event-free survival outcomes. This highlights a significant heterogeneity within trial-eligible populations and provides a critical real-world baseline for evaluating the true benefit of adding intensive perioperative systemic therapies. For patients who do progress to advanced stages of prostate cancer, systemic management continues to evolve rapidly. A comprehensive review published in the BMJ summarizes the major therapeutic advances across high-risk biochemical recurrence, metastatic hormone-sensitive disease, and metastatic castration-resistant prostate cancer. The authors emphasize that the earlier integration of androgen receptor pathway inhibitors has fundamentally improved patient outcomes in both biochemical recurrence and hormone-sensitive metastatic disease. Meanwhile, the castration-resistant population has become highly diverse, driven by varied prior treatments and distinct biological features. The review highlights how advanced imaging and genomic biomarkers now allow for highly personalized therapy, refining the roles of chemotherapy, PARP inhibitors, and lutetium-177, PSMA-617. As patients live longer with these advanced therapies, the authors urge clinicians to focus on proactive management of treatment-related toxicities, including cardiac, hematologic, and bone health issues. In reconstructive urology, managing urethral strictures remains a common clinical challenge, and a multi-center study in the World Journal of Urology compared two endoscopic approaches. The retrospective analysis evaluated direct visual internal urethrotomy against the Optilium drug-coated balloon dilatation in 140 patients with anterior urethral strictures under 3 cm. Although the drug-coated balloon group was much more heavily pretreated, with over 3/4 having undergone prior stricture treatments compared to less than 10% in the urethrotomy group, the stricture-free survival at 12 months was nearly identical, at 68% for the drug-coated balloon and 67% for internal urethrotomy. Complications were low in both groups, and patients in the drug-coated balloon group reported significantly better symptom scores at 3 months. This suggests that drug-coated balloon dilatation is a highly effective option, showing comparable safety and intermediate-term efficacy, even when used as a salvage strategy after failed endoscopic treatments. For more severe urethral trauma, such as pelvic fracture urethral injuries, initial and long-term management strategies require careful coordination. A review in European Urology Focus highlights that while acute management must prioritize trauma resuscitation, clinicians must prepare for the high likelihood of urethral stenosis, which occurs in over 90% of these patients. The review notes that the timing of initial management for complete urethral injuries does not significantly affect future stenosis rates or the complexity of subsequent reconstructive surgery. The authors recommend that the optimal time for urethral reconstruction is between 3 and 6 months, once major orthopedic injuries are fully stabilized. They strongly advise against endoscopic procedures for the delayed management of post-traumatic stenosis, favoring perineal anastomotic repair as the primary surgical method due to its high success rate, and noting that robotic platforms are becoming increasingly useful when abdominal access is required for complex cases. In benign urological conditions, conservative management is often the most appropriate starting point. A review in European Urology Focus reinforces that self-management should be routinely considered as a first-line strategy for male lower urinary tract symptoms. This approach offers modest symptom improvements and short-term outcomes that are comparable to pharmacologic therapy in select patient populations, serving as an effective low-risk option that can be utilized alone or in combination with medications. When surgical intervention for benign prostatic hyperplasia is necessary, holmium laser enucleation of the prostate is highly effective, but the efficiency of tissue removal is heavily dependent on the morcellation device used. A systematic review and meta-analysis in BJU International analyzed 22 studies involving nearly 6,000 patients to compare the safety and efficiency of different prostate morcellators. The analysis revealed that oscillating blade systems such as the Piranha morcellator achieved a higher unadjusted tissue removal efficiency of nearly 8 grams per minute compared to less than 5 grams per minute for reciprocating systems like the VersaCut. In volume-adjusted analysis, the reciprocating system was significantly slower, with the performance gap widening further in larger prostates. Additionally, the reciprocating device was associated with more than 3 times the risk of bladder mucosal injury compared to the oscillating system, demonstrating that oscillating blade morcellators offer a superior safety and efficiency profile, particularly in larger glands. For patients suffering from refractory overactive bladder or non-obstructive urinary retention, sacral neuromodulation offers a durable therapeutic option, but long-term device retention is a key clinical consideration. A 12-year retrospective study from a high-volume Canadian tertiary center evaluated 587 patients who underwent sacral neuromodulation. The study demonstrated excellent explantation-free survival rates of 97% at 1 year, 92% at 3 years, and 81% at 5 years. No baseline clinical or procedural variables were independently associated with the risk or timing of explant. Among the minority of patients who did require device removal, the primary driver was a loss of therapeutic efficacy, which accounted for nearly 58% of explants, followed by patient preference and pain. This provides highly reassuring long-term data for counseling patients on the durability and expectations of sacral neuromodulation therapy. If you only have time for one paper this week, make it the prospective study on prostate magnetic resonance imaging quality from BJU International. This study provides compelling prospective evidence that high-quality imaging and centralized expert review significantly improve diagnostic accuracy while reducing indeterminate findings, making a strong case for routine quality control before proceeding to biopsy. Here are the key takeaways from this week in urology. First, interactive electronic visits incorporating personalized risk estimates can improve patient screening decisions and testing rates, though outreach must address demographic disparities in tool completion. Second, prioritizing high-quality multiparametric magnetic resonance imaging and expert central review is essential to optimize prostate cancer detection and minimize unnecessary biopsies. Third, for anterior urethral strictures under 3 cm, the Optilium drug-coated balloon offers equivalent 12-month stricture-free survival compared to direct visual internal urethrotomy, serving as a viable option even in highly pretreated patients. Fourth, in holmium laser enucleation of the prostate, oscillating morcellators provide superior tissue removal efficiency and a lower risk of bladder mucosal injury compared to reciprocating systems, particularly in larger glands. Finally, sacral neuromodulation demonstrates strong long-term durability, with over 80% of patients retaining their device at 5 years, and loss of efficacy remaining the primary driver of eventual explantation. That's your roundup for this week in urology. The full transcript and references are available on the episode page in your Audio Scholar library. This is an AI-curated summary. For clinical decisions, always consult primary sources and current guidelines. See you next week. If this weekly briefing is useful, follow the show in your podcast app so new episodes arrive automatically. And for audio briefings on your own clinical questions and papers, visit audioscholar.cc. This is an automated summary generated by artificial intelligence, which can make mistakes. Always review the original source materials.